Good morning, everybody. This is the Committees in Common meeting for Improving Healthcare Together 2020-2030. My name is Jonathan Perkins. I am the appointed convener of this Committees in Common meetings for the two CCGs of NHS South West London CCG and NHS Surrey Heartlands CCG. I just wanted to say that the purpose of this Committees in Common today is to enable the members of those two committees to consider together and at the same time the same issues in connection with any significant change to the commissioning of acute services at Epsom and St Helier University's Hospitals Trust. This meeting is being held in public and it is currently being live streamed so that the members of the public and external stakeholders can view our proceedings. We would have obviously preferred to have had this meeting all together in the same room, but we can't do that due to the COVID-19 restrictions. And so we are meeting in public using this live stream. And in a moment, I will just go through a few guidelines for the meeting for participants so that we make the meeting as efficient as it possibly can be while we're online. But I think first what I'd like to do is ask the two clinical chairs of each of the committees to introduce their committees to us all. So I wonder if I could go to you first, Dr. Andrew Murray, to first introduce yourself, obviously, and the members of your committee.
Thank you very much, Jonathan. Can everyone hear me okay? Is that working? Excellent. So I'm Dr. Andrew Murray. I'm the GP chair of NHS South West London Clinical Commissioning Group. I'll start by introducing the voting members of our committee who are present here today. So voting in this context are Susan Gibbon, who's our lay member for patient and public involvement, Vasa Nalapragasam, GP chair of Merton Borough Committee, Dr. Jeff Croucher, GP Chair of Sutton Borough Committee, and Sarah Blow, the Accountable Officer for the CCG. In attendance, we also have Pippa Barber, who's our independent nurse on the governing body. We have Paul Gallagher, who's our lay member for audit on the governing body. Lucy Waters, who's the Locality Executive Director for Sutton as part of the South West London CCG, and James Blythe, who is the equivalent in Merton. We also have in attendance Healthwatch representatives, so we have Pete Flavell from Sutton, and we're expecting Dave Curtis, the Merton Healthwatch representative as well, all in attendance.
Andrew, thank you very much for that. Dr. Charlotte Caniff, can I ask you to introduce the members from the Surrey Heartlands CCG, please?
Thank you, Jonathan. So I'm Dr. Charlotte Caniff. I'm the clinical chair in Surrey Heartlands CCG. And with me today as voting members, we have Jackie Burke, our audit chair, Julia Dutchman-Bailey, our registered nurse on the governing body, Russell Hills, our GP clinical leader for Surrey Downs ICP, and Matthew Tate, our accountable officer for Surrey Heartlands CCG. And in attendance, we also have Colin Thompson, ICP Director for Surrey Downs, and Kate Screbbins, Chief Executive of Healthwatch Surrey.
Charlotte, thank you very much indeed. Our terms of reference for our committees in common also allows the committees to call additional individuals or experts to attend meetings to help inform the discussions of the committees as necessary. So there are some of those individuals and experts on the call today, so perhaps I should just introduce those people as well who we'll be hearing from later on. So first of all, from the Improving Healthcare Together programme, we have Andrew Dimitriades, who's the director of that programme.
Hello.
And we also then have James Murray, who is the Chief Finance Officer for South London CCG. And then hi James, and then from Epsom and St Helier University Hospitals NHS Trust, we have the following. We have Daniel Elkeles, the Chief Executive Officer. Hello. We have Dr. James Marsh, the Deputy Chief Executive, Joint Medical Director and Consultant Renal Physician. Hello. We have Dr. Ruth Charlton, Deputy Chief Executive and Joint Medical Director and a Consultant Paediatrician.
Good morning.
We have Dr. Amir Hassan, who is Clinical Director of Emergency Medicine and Consultant in Emergency Medicine.
Good morning.
And we also have with us Arlene Wellman, who is Chief Nurse and Director of Infection Prevention and Control.
Good morning.
Good morning, Arlene. Thank you. And then we also then have two people attending from Opinion Research Services. So we have Charlie Wilson.
Good morning.
And we have Kester Holmes as well.
Good morning.
And last but by no means least, we have Brian Niven with us this morning from McDonald.
Morning.
Morning, Brian. So I'd just like to remind those who are participating in the meeting today that because we're doing it online, there might be a slight lag and might be slight delays. So please just be patient with the technology. If you'd like to ask a question, please do raise your hand either using the icon or physically waving your hand, but by preference the icon if possible, because it may be that I can't see everybody on my screen. And once you've raised your hand electronically, it'd be helpful if you could then lower it as well. And please keep cameras switched on throughout the meeting. And then finally, and I think everyone's very good at this now, but if you're not speaking, it's really helpful just to go onto mute, and so that we don't get feedback issues or other interference in the noise. If anyone has any issues in the meeting, again, please just raise your hand and we'll try and sort that out for everyone. So that's where we are on that. I'd just like then finally, Chairs, I asked you to introduce your committees, but I didn't then ask you also to confirm to me that you were therefore quorate. I assume that's the case, as I think you're fully staffed up, but I can see nods from both Andrew and from Charlotte, so thank you for confirming that just for the record. So I'd like to then go on to the second item on the agenda, which is declarations of interest. And for everyone who is a voting member of the committee, each of the two clinical commissioning groups, Surrey, Heartlands and South West London, for both of you, the declaration of interest from every member is disclosed and published on the public websites, and so they are there for this meeting. But I'd just like to pause there because we need to check to make sure that there aren't any updates to those disclosed conflicts from anyone, and just to check there aren't any particular conflicts which relate to the subject matter of the business of this meeting. So I'm just going to pause there, and please do raise your hand if you'd like to either update your conflicts or make a specific point about conflicts of interest. So I can see shaking of heads and silence and no raising of hands. So I will confirm that we have dealt then with our declarations of interest. So moving swiftly on then to the third item on the agenda. The last meeting we held was earlier this year in January, the 6th of January, when we met to consider the consultation document. And we have before us the minutes of that meeting, and I think it's our duty now just for each committee to approve those minutes if you'd like to do so. Again, I'm not going to turn the pages, I'm just going to pause So perhaps I can pause and ask the chairs of the two committees just to let me know if they are aware of any changes that need to be made to these minutes from the 6th of January. So Andrew, I can see you're shaking your head.
We've looked through them and we're happy they're accurate.
Thank you very much, Andrew. And Charlotte, from your point of view?
Likewise, no changes, thank you.
So no changes from either committee. So we will approve those as a accurate record of that meeting. So thank you. And those minutes will then be posted onto the website for the programme, the Improving Healthcare Together website. So thank you for that. At this stage, you people attending might just notice that at that stage we had 3 committees, and we have 2 committees now. This is because certain mergers took place from the 1st of April this year, 2020. So just to clarify that, so Surrey Heartlands CCG was formed as a new organisation, and that comprises Surrey Downs CCG and 3 other CCGs, clinical commissioning groups in Surrey. So that is why Surrey Heartlands is now a member of this Committees in Common. And in a similar way, South West London CCG was formed on the 1st of April, and that comprises Sutton and Merton CCGs, together with 4 other CCGs in South West London. So that is just to explain to people why we now have 2 committees sitting in common rather than the 3 we had at our previous meeting. So that concludes those pieces of business, and then I'd like to move then swiftly to the final thing, I think, is to adopt the terms of reference, because we have these 2 new organisations. Both organisations, Surrey Heartlands CCG and South West London CCG, both updated and approved the terms of reference for these committees in common at their own bodies. So I'd just like that then to be adopted for the benefit of this meeting. So again, I'm just looking at both the chairs of the 2 committees, both to Andrew Murray and to Charlotte. I can see you both nodding, so I will take that, if that's all right, as confirmation that we formally adopt those terms of reference which for this meeting. Great.
Yes, thank you, Jonathan.
That's excellent. So I think we can now move into the main business of the meeting, and I am going to hand over then to Andrew Dimitriades to talk to us about the decision-making business case. Andrew.
Thank you, Chair. So what I'd like to do in the next couple of slides is just take people through, in brief, the journey that we've been on as a programme, and bring us, I think, up to date really within the context with which we're holding the decision-making meeting. So I just wanted to remind colleagues that we came together as a programme, the Improving Healthcare Together programme 2020-2030, over 2.5 years ago, in January 2018, and we came together importantly to try and address the significant challenges, long-standing challenges that had been identified at Epsom and St Helier, and to look at developing proposals with our clinicians in partnership with the CCGs affected, and to look at how we might develop a solution that can make Epsom and St Helier a sustainable provider of services in the future. And there are 3 significant challenges, all of which I know we've rehearsed many times at the programme board, but also through the governing body discussions that we've held over that period. And in brief, those 3 challenges still remain clear and need addressing. The first is around the clinical challenge, or the quality challenge, as we've expressed, in that we don't have enough specialist doctors, nurses and clinical staff for some of those essential and important emergency services. And that for those emergency services, we've called them major acute services, we are not able and they are not able to meet the clinical standards for care that patients deserve and expect. The second challenge is around the estate and the fabric of the Epsom and St Helier sites. As people know, many of the hospital buildings are older than the NHS, and given the recent inspections that occur regularly, over half of that hospital space has been assessed as not being suitable for modern healthcare. So we need to invest significantly in all the sites for healthcare going forward. And then the final challenge, which is connected to the quality and buildings issues, as they contribute to the trust having a worsening financial position, is that we need to try and find a way to put the trust back onto a sustainable financial footing and address that. And we think the best way to do that is to propose a different way of organising services. So the journey that we've been on has gone in 5 stages. Firstly, that we worked and have worked very closely with our clinical colleagues, both within the CCGs and at the Trust, to help define a clinical model for the future. And that we've done a process of extensive engagement around that. Colleagues will recall we set out a case for change and an issues paper quite early on into the programme, and we both learned from that experience in terms of the issues that were important, but we've developed in fact a continued stream of evidence to help us establish a preferred option. That preferred option, along with the other options that we consulted on, which started in the spring, which started in January and concluded in the spring, asked our local population and a wide group of stakeholders for views on those options. We commissioned an independent report, and we're going to hear from the provider who undertook that analysis, Opinion Research Services Limited, who developed the analysis of that consultation process. And as members of the gun bodies will know, we've looked in a lot of detail at the emerging themes and the potential responses, which I'll go on to talk about later in my presentation, as part of thinking about what the impact is on the options that we've set out. I was absolutely delighted that at the end of the consultation process, we were awarded a best practice certificate from the Consultation Institute, who have been invaluable really in offering their advice both in the run-up to consultation and indeed through our pre-consultation activities. We published the consultation feedback and the reports, and then subsequent to that, in view of the information that was in that consultation analysis report, and again I'll talk about this later in my presentation, we finalised the third phase of the integrated impact assessment with the help of Mark MacDonald, who independently ran that further analysis. And we've looked at all of that information as we've been developing the document that we published last week as an acronym on this slide, so apologies, the decision-making business case, which sets out our proposals and recommendations for the future. And bringing us right up to date, the committees in common today will hear a cross-section of the evidence that has been developed in order to make the best decision about the best solution that delivers, that addresses our case for change and delivers a clinical model that is fit for purpose for the future. So Jonathan, I'm going to drive the slides, I think, subsequent to other members joining us. I'm now going to go on mute, and I think we've got Dr. Andrew Murray, who's just going to remind us about the clinical model.
Certainly happy to take over, and thank you very much, Andrew. I've got a slight echo, is that? That's fixed, good. I know that everyone is very familiar with the clinical model, but we thought it was important, given we're talking about a £500 million investment into Epsom and St Helier hospitals, to remind people of the clinical model and what that investment will bring us in terms of benefit to patients and improvement in quality and better health outcomes and the lives that we can save through delivering this. As a clinician who's been working in South West London for 20 years, obviously I recognise all the challenges that Andrew set out in the previous slides, and it was a real privilege to be part of the clinical advisory group overseeing the work on the clinical model. We had diverse multi-professional input into the clinical advisory group from primary care, but also from across Epsom and St Helier NHS Trust, and that also applied to all the different working groups we had, which looked at the particular specialist areas we're considering. There are two key elements to the clinical model. So the first one is the district hospital model, and I'll start with that. And as you all know, we're planning on retaining 85% of services at both Epsom and St Helier Hospital, and we'll be reshaping those services so that they really meet the needs of our surrounding communities. We'll have roughly 500 beds across both hospital sites, and what we'll be able to deliver on the district hospital sites is set out here in this diagram. So I'll just go through it step by step to remind people. We'll be delivering outpatient services, diagnostics, planned care, including day case surgery, rehabilitation, and a lot of the focus on the beds will be allowing people to step down from more specialist care into a rehabilitation setting where we'll have specialist multidisciplinary teams supporting patients effectively, but also allow the right patients to step up into those beds from the community. And then we will also have an urgent treatment centre on both the Epsom and St Helier sites, which will be open 24 hours a day. And as many of you know, roughly 2/3 of patients who are currently seen in A&E departments can be dealt with more effectively and quicker in an urgent treatment centre. So that's the model, the district hospital model that will be delivered at the sites. And then the plan is to bring together 6 specialist services onto one site, a new build specialist emergency care hospital, either on the Epsom, St Helier or Sutton hospital sites. So the services that we'll be bringing together, and remember that the purpose of that is so that we can bring all the specialists together, so that we have the right consultant numbers, a single team working in unison, because we know that that improves the quality of care. It helps us to meet clinical standards and improves outcomes for patients, so it saves lives. So we're very excited about the opportunity to do that. The 6 key services we'll be bringing together are major emergency departments, so for the very sickest patients who currently attend A&E. Acute medicine, which deals with conditions such as severe pneumonia. Critical care, which underpins a lot of the other services we have on site. Emergency surgery, which requires access to critical care. Births, so all inpatient births will be done on the specialist emergency care hospital site, and then inpatient children's services and beds. So we looked at 3 options. We looked at Epsom siting the specialist emergency care hospital, in which case you can see that's the top line. You'd have urgent treatment centres on both those sites. We looked at St Helier as a specialist emergency care hospital, and again that mirrors the Epsom model, so with district hospital services on both Epsom and St Helier, but the specialist emergency care hospital on one of those sites. And then we also looked at the third option, which was continuing to have district hospital services at both Epsom and St Helier, and building a new standalone specialist emergency care hospital on the Sutton site next to the Royal Marsden Cancer Hospital. So next slide. As you know, we went through a really thorough process to evaluate the options and to rank them. We decided that Sutton was the preferred option, and there's a number of reasons for that. It provides the best option for high quality services for everyone living across Sutton, Merton and Surrey. It's a central location for the specialist emergency care hospital. It has less of an overall impact on travel when you consider both older people and deprived communities across Surrey, Sutton and Merton. And really importantly, it does build a brand new third hospital, and therefore allows us to have a third urgent treatment centre on the Sutton site rather than just 2 in the other options. And of course, as you know, because we've been through this process together, there are also financial benefits to the Sutton option. It's the best option financially and also the quickest and easiest to build. So that led us to ranking Sutton as the top ranked option, with St Helier as the second ranked option and Epsom as the lowest ranked option. Obviously we consulted on all three options, but we let people know at the start of consultation that Sutton was our preferred option. So I think I'm now going to hand over to Charlie and Kester from Opinion Research Services to talk about the public consultation that we held, where we presented just what I've described to the public and asked them for their opinion.
Yes, thank you very much, Andrew. Thank you, convener and committees, for the opportunity to present a very brief summary by necessity of some of the key findings from the consultation feedback report, after which I'll hand back to Andrew so that he can expand further on some of those themes in a broader context. So consultation is intended as a dialogue based on an exchange of views. It isn't a vote or a referendum to determine future action, but of course the feedback received is extremely important. As mentioned by Andrew, there was a period of pre-consultation engagement with a formal consultation on the proposals taking place in early 2020 over a period of 12 weeks. And members of the public and other stakeholders were able to participate and provide feedback through a wide range of channels. Next slide, please, Andrew. So substantial effort was made to engage widely with public and stakeholders, and that's one of the key factors in the quality assurance process undertaken by the Consultation Institute that Andrew mentioned. And that included producing accessible consultation materials, large-scale distribution of those materials to households and in publicly accessible locations, promotional activities, and also activities via social media and traditional media and the IHT website. Importantly, specific work was undertaken to engage with hard-to-reach and seldom heard groups, including those who might be disproportionately affected by the proposals, and work undertaken to ensure that feedback was received from representative sample of the population in the area. So the consultation strands we see on this slide included some undertaken by independent research organisations, ourselves, ORS, YouGov and Ipsos Mori, as well as public engagement activities and meetings undertaken by IHT, individual CCGs and CDS organisations. There were a large number of submissions from the public and stakeholders, several petitions and locally organised questionnaires or surveys also took part. I'd like to particularly mention the work of health watch organisations, including Surrey, Sutton and Merton, in promoting the consultation and really encouraging that public engagement. Next slide, please, Andrew. In terms of key findings related to the case for change in the clinical model put forward in the proposals, many of the consultees did recognise the challenges identified in the proposals which face the NHS both nationally and locally within the Trust. And the proposed model of care did gain broad support across different respondent types and looking across the geography of the catchment area as a whole. However, and this is really discussed in detail in the report and has been discussed in previous meetings, the levels of support did vary by geography, and more residents in the wider Merton CCG area in particular viewed the proposed model of care as poor or very poor. With regard to feedback on potential sites for a new emergency care hospital, then again looking across all of the different consultation strands, respondent types and broadly across the geography, Sutton as a site received broader support than either Epsom Hospital or St Helier Hospital. But again, as previously discussed, there was localised support for St Helier, and there were also some objections to any centralisation of major acute services and calls for acute services to remain at the current hospital sites. So next slide then please, Andrew, and we'll consider some of the those written submissions also via email, via the questionnaire and via the IHT provided text messaging services that were received. There were over 400 of those, and they were from both members of the public and also from some stakeholders, and we see a list of those stakeholders here, which included clinical groups, local authorities, elected members and political groups, and also trade unions and other organisations, as well as I mentioned, as a large number of members of the public who chose to write or email. And some of those were very detailed, in particular coming from some of the local authorities. And on the next slide, Andrew, we'll look very briefly at responses from 7 of the local authorities who provided responses. And initially looking at the 3 councils representing the 3 CCG areas, as it was when there were 3 CCGs at the beginning of the consultation. We see diverse views there. So Merton Council commissioned their own independent advice, which they submitted alongside the formal response. And they opposed strongly the model of care, challenging both the evidence and the rationale presented with the proposals. By contrast, Sutton and Surrey councils both expressed support for the proposals, with Sutton Council preferring the St Helier site for a new SCCH on the basis of, among other things, travel and access, particularly for people living in deprived communities and to avoid increasing health inequalities. Surrey Council highlighted several issues, including the need for extensive engagement and mitigation measures in relation to travel, access and other potential impacts should the proposals go ahead, and that the SCCH should be built at the preferred site of Sutton. Looking then at the next slide of other local authorities who responded. Are you able to move to that slide? Thanks, Andrew. So Epsom and York Borough Council supported the model of care and expressed the view that the new SCCH should be built in Epsom, and they particularly highlighted the needs of a growing and ageing population in that area, among other issues. The Royal Borough of Kingston sought assurances that efforts would be made to limit potential impacts of changes, and that specific services such as postnatal and antenatal care would remain at the local district hospitals. Reigate and Banstead Borough Council and Wandsworth Council were supportive of the model of care, including the preferred site, with calls for partnerships and cooperation between partners and stakeholders. And Reigate and Banstead Council in particular specifically expressed a view that was forthcoming from across the consultation response from all strands and all respondent types, that investment and refurbishment and retention of local urgent care facilities at existing hospital sites are absolutely vital if the proposed changes go ahead. And so I would just like to take a moment to thank all of the members of the public and stakeholders who responded via feedback, and I'll hand back to Andrew then to continue.
Thank you, Charlie, and a big thanks to RS for all their help with the analysis. So what I'm now going to do is just to try and talk you through and link the further work that we've done across the CCGs, looking at the key themes from consultations and the response that we think is appropriate to take going forward, or indeed for potentially the trust to take forward in its further work. And this section of the presentation will link with a further element of the presentation that we've got later, which Sarah's going to provide, which looks at the recommendations that have been made in the decision-making business case and which we'll be considering today. So what we've looked at is 7 broad headings for what are essentially cross-cutting themes that came out of the consultation and the feedback linked to that, and where we've needed to develop either further evidence or considered what the potential impact would be on the overall ranking of the options. And that will be an important, I think, discussion that we have subsequently within the committees in common about what does this tell us really about the ranking of options and the impact. So there's 7 areas. The other category covers a whole range of issues that have been identified. Clearly, I can't take you through every single issue and response, but what I'm going to try and do is talk you through the main elements. So the first is around travel and access. And what we heard loud and clear through the consultation, it was the most common concern, as Charlie has said, was that access to services and the impact potentially of the changes on local communities and travel and transport to the proposed specialist emergency care hospital is very central to people's concerns. We've looked at a whole range of things linked to that. We've had some very detailed submissions. So one of the actions that we took around the issue around access was to update the travel analysis. And I'll go on to say a little bit about that in terms of the updated integrated impact assessment. But we've refreshed the data that's available to us, and we found that it does not materially change the time it would potentially take to get to the specialist emergency care hospital, either by public transport, private transport, or through emergency transport. But we know that we need to improve access to the sites, and through this, potentially to look at extending the current hospital shuttle bus, which I think is locally known as the H1. And what we've considered is extending that bus route and asking the Trust to look at making further provision to extend the route between Surrey and Merton, thereby improving access and transport for patients, visitors and staff to get between sites. There are clearly some wider public transport issues that we think will need addressing in due course, and therefore one of the requirements that we've set out in the outline that we've set out in the decision-making business case, which we would seek the Trust to address, is that as part of their further planning, that they would need to conduct a detailed travel and access assessment and publish a plan. We would see them doing that in partnership with relevant transport providers at local authority level, the voluntary sector, and indeed anybody that has, I think, an interest, I guess, in travel and transport. And we've detailed that in the decision-making business case. 2 other things I'll just mention on this slide. Secondly, that we recognise that parking capacity and having sufficient car parking capacity in all of the options and across all sites is vital in the future. We know that there will be changes in the way people get to their sites. Indeed, there'll be changes in the way in which I think people receive care in the future. But we've sought assurance that through the further planning work that the Trust will do is that they will be able to accommodate the predicted numbers of staff, patients and the public. And then the final point I wanted to just highlight on this slide is that and this cuts across all of the work that we've done considering the issues in response to consultation. Our clinical advisory group has continued to meet, and it's further considered the range of district services that would be provided, and they have recognised the link with the out-of-hospital services in primary and community services, many of which are accelerating in their development and will continue to do so, and that the district sites will absolutely have to work in tandem with any further out-of-hospital developments. The second area, which links in with my point about the clinical advisory group, is that there was, whilst there was widespread report, as Charlie indicated earlier around the case for change, there was differential support depending on where you lived. We recognise that potentially introducing a new service model will be a challenge to ensure that there is an appropriate level of understanding by members of of the public and visitors and carers, and we've discussed with the clinical advisory group about the need to further develop a comprehensive communication and engagement plan in order to ensure appropriate patient education and signposting, not just to district services, as Dr. Murray said earlier, which 85% of which people will still be able to access local services, but also about what will be available on the specialist emergency care site. And then one final point, I think, on this slide, which we know was a key issue during consultation, and one that we've worked hard to discuss on a continued basis with other providers, is that in recognition for the fact that there will be some change potentially in patient flow, depending on which option is selected as the final preferred option, our provider colleagues have confirmed during consultation that all of the options are deliverable, but of course there's more work that we would ask the trust to do to work with those providers post-selecting a preferred option in order to look at refining, I think, the assumptions around activity and, if needed, the planned investment that is necessary. However, our financial assumptions in the model do contain the cost, the capital that would be required to support any of the options. So those were the 2 points I wanted to make on that slide. Workforce continues to be an area that presents a challenge day to day for the trust, as we know, but in introducing any new form of clinical model, it will be dependent on having the required staff available to staff potentially all of the sites where care is delivered, and that they've got the skills and the training needed to deliver high quality care. So we know that there's public support in broad terms for the case for change, although that depends on geography, and we have gone round the loop again in terms of a discussion with our clinical advisory group to look at the workforce challenges. And they have confirmed very clearly that there are no other solutions that they see are able to address the current case for change that we've set out, and therefore we have not looked again at any other solutions to address the challenges, as we don't believe there are other viable solutions. We know that there's more work that the trust needs to do to look at this issue, and as set out in the outline, in the decision-making business case rather, we will ask the trust to develop a detailed workforce implementation plan to look at its recruitment and retention plans and strategies, and it will need to work in partnership with Health Education England, the Royal Colleges, local clinicians and stakeholders to ensure that that plan can be implemented. Available capacity in the future, again, was and having sufficient beds to meet the future demands of the population, as we have an aging population going forward, was a key element of the consultation, and that remained a concern as we went through that process. We have looked again at the bed modelling that we did in the run-up to publishing the figures that were contained in the pre-consultation business case, and we had a number of requests to extend the time horizon for our bed modelling, which in the original submission that we made was modelled to 2025, but we've extended that to the end of the decade, and we've also looked again at the potential housing developments linked to each of the areas where the sites would be. On that basis, there will be a required further increase in the number of beds that we think the Trust will need to provide for, with which will give a requirement for a total increase of 18 beds from the current bed base of 1,048 that the Trust delivers. And we think that's an important feature to recognise in the revised assumptions going forward. And I'll just mention briefly that the Mayor of London, who has recently conducted his review of our proposals, also raised this as an issue. But I'm clear and satisfied in the work that we've done that we have addressed those concerns. We also asked the Trust, and I know this is something that we will pick up later in the conversation, to look at what flexibility each of the sites has in future should there be a significant increase in demand that is required. And we heard from the Trust and have heard previously at the discussions that we've had in the joint governing body seminars, there is flexibility across all three sites to provide for further increases in capacity beyond that fairly modest increase in beds that I've just outlined. Health inequalities and the potential for adverse impacts of proposed changes has been a very strong theme that we have considered, both in the run-up to consultation, given that we commissioned an independent deprivation impact study, the work that Mott MacDonald have done in terms of their impact assessment, and this links very, very closely to the challenges around travel and access for our population. And we've done a number of things since consultation closed. One is that we asked Mott MacDonald to do some additional deprivation analysis to assess the impact on health inequalities. And in the report that we received and published recently from Mott MacDonald, they do highlight the importance of district and out-of-hospital services as being one of the key elements that can reduce the impact on those deprived groups and populations, but only if that is done earlier on in the pathway, and that there is a clear emphasis there on the importance of primary and community services and making sure that they're available to the local population. And I think the final 2 points in this slide really support that view. That there is strong evidence that it is not acute services in their own right that will deliver an improved set of outcomes for patients, but looking across the spectrum of care that's available, that will only, if those services work together, reduce health inequalities for people and improve their life chances. A key theme that was touched on earlier and links to the workforce, I think, arguments is around a concern about multi-site working and the potential for there to be different levels of care provision with district services providing only basic services and of course those that were provided at the specialist emergency care site. One of the issues that we've debated at the clinical advisory group has been around looking at ways in which the sites and the services can work more effectively together, including primary and community services. They've looked again at the data around the level of patient transfers, which they believe would be very small, I think, between sites, but there will need to be an appropriate differentiation between patients so that patients get to the right sites as effectively as possible, and that patients are stepped down appropriately between the specialist emergency care site and the district sites appropriately, and that all services work seamlessly to deliver that. There are a number of recommendations that are also detailed in the impact assessment, which I'll go on and say something about. relation to environmental considerations, which the Trust will need to address, and that we've also reinforced the need that for the sites to work together effectively, for patient information to be exchanged between clinicians, and for clinicians to be able to talk to each other appropriately, the centrality of having an electronic patient record, which we've included in the financial sums of the case, need to be developed and accelerated, and we would like that delivered in advance of the specialist emergency care hospital. And then a final question that I know is a worry for all, which is about whether or not funding will continue to be available for the scheme that we are proposing, and we are continuing to be in dialogue with the Department of Health and as is the Trust directly, and they have confirmed that Epsom and St Helier Hospital and Improving Health Together remains one of what's called the Health Infrastructure Plan first wave priorities, and that 500 million is available to us going forward. And then the final set of issues that came up during consultation, and we've selected only a number here that we felt that these were the most important to share with the committee today, but of course people can read the decision-making business case as it's set out. There are three key areas that I wanted to mention. One is around renal services. During consultation, we received a letter from the St George's and Epsom and St Helier renal physicians that talked about the potential to consolidate renal services in a specialist centre, and could potentially therefore deliver improved outcomes for patients. We've debated this at the programme board and also through the joint governing body sessions, but we have discussed this at the clinical advisory group, who saw merit in those proposals, but we've agreed that that should be kept separate from the Improving Health Care Together process, and that any further work that's needed to appraise the benefits and impact of that proposal should be subject to a separate process. I'm not going to mention too much about the impact of the COVID-19 pandemic, because I know that Dr. Caniff's going to say a few words later. The only thing I would suggest that I would remark upon, I think, here is that we have done an interim assessment with input from Epsom and St Helier to look at what that impact might be on the clinical model. We know that there's more information that we're going to need to consider, but that does emphasise, we feel, change is even more important, even though we can't fully learn the lessons as we stand, or rather as we sit as a committee today on that. But I'll let Charlotte say something about that. And then after consultation, we received a letter from the chairs of the Merton and Sutton Health and Wellbeing Board, which talked about the potential, in the event that St Helier was not the preferred site for the specialist emergency care hospital, they wanted the governing bodies to consider whether there was the potential for further services to be made available on the St Helier site, ranging from child development services, mental health services, and indeed primary care services, and asked us to think about that in our considerations going forward. We've discussed that. We think in principle that there are enormous benefits about the potential, not just for further enhancements to district services on the St Helier site, but they could also be available if there was a need, and clinical support for them, and patient support for them on the Epsom side. But it would be premature to conclude how best to dispose of those services at this point in time. But there is a commitment that we should work in partnership, in particular, with the local authorities, patient groups and other providers, to look at the potential for those services, but that would be outside of the process that we're going through today. But there was support and is support for that. And then finally, just a word on the integrated impact assessment, because a lot of work has gone on, and I wanted to just acknowledge the work that has been done by Professor Andrew George, who was the independent chair of the steering group, who has chaired all of the work that we've done around the impact assessment, but has looked at and considered through that group some further updates around the evidence gathering once consultation closed. And it's worth saying that whilst many areas in the integrated impact assessment stand as they are, the important things that were looked at was one, around updating the what's called the indices of deprivation, looking at whether or not there are changes in which wards are affected or are the most to the least deprived. I mentioned earlier that the travel times information was updated, and that they have further developed the analysis of deprivation, and they also make a point about sustainability and COVID-19 into the future. What you'll see when Sarah talks later about the recommendations is that we have tried very hard to link what's called the IIA enhancement or suggested actions to the potential recommendations that we want the committee to look at, and that will feature in that presentation, although we're not going to go through all of them. So in summary, we have looked at a lot of evidence, and I have been keen to ensure that the governing bodies and indeed the programme board under David Clayton Smith's stewardship have gone through a comprehensive process of deliberation, and that this has absolutely been integral to the CCG's governance and decision-making process. We were very clear early on about what that decision-making process looked like and the stages that were involved, and we followed that very much to the letter in arriving, I think, here today. So these bullet points are important. We've collated the feedback and evidence and consultation into the report that ORS produced for us. We have reviewed and deliberated on the findings, I think, in some detail. The IIA has been concluded and suggests the enhancements that we might take. And we've done quite a lot of further analysis and review work through the clinical advisory group and the other governance groups as part of developing the decision-making business case. I think we've got a clear set of recommendations that link to these. And then given that any form of service change has a myriad of different both statutory and legal implications and requirements, I would like to say that we have complied with all of the relevant legal duties in considering our work, and I'm not going to go through all of these, but in the relevant elements of work that we've done and that we published. I'm sure we could have expanded upon this, but you'll see the relevant legal duty on the left-hand side of this. Ranges from everything around our public sector equality duty to the duty of public involvement, and I think we have followed that as rigorously as possible. So that's what I wanted to say in response to the consultation themes and areas, and I think at this point I will go on mute and hand over just briefly to Dr. Caniff to talk a bit about COVID-19.
Thank you, Andrew. Hopefully everyone can hear me okay. So, I mean, the COVID-19 pandemic has truly tested both the current clinical infrastructure at Epsom and Helier and our proposed plans. It's shown, despite clearly heroic efforts from our Epsom and Helier colleagues, the difficulty of tackling a modern pandemic in old hospital facilities. The interim assessment of the impact of COVID-19 on proposals certainly highlighted the need for change, and in fact has strengthened the clinical model outlined in the decision-making business case. And particularly this include for our sickest patients on one site, with state-of-the-art facilities and specialist teams to care for those sickest patients. It also highlighted the need to review the detail in the design of both the SETCH and the DGH, the district journals, to reflect some of the learning. For example, we need more single rooms and more piped oxygen. We need flexible spaces to allow the opportunity to close off areas or open up areas as needs would require. And we need more hand washing facilities close to patients' beds. We also need to develop strong local community and primary care services and partnerships to allow care for our patients to be had close to their homes. And finally, it's shown us that we need to work together across boundaries to ensure that the needs of all groups facing health inequalities are met, including our BME, deprived and vulnerable communities. Developing services that support long-term conditions by investing in primary care and improving life opportunities for all by addressing lifestyle, housing and employment issues. And when communities do need urgent access to health facilities, the preferred option would enhance access by providing 3 urgent treatment centres with 24/7 opening 365 days of the year. Thank you. I'm going to hand over, I think, to Matthew.
Good morning, everybody. Matthew Tate here. So I'm just going to spend a couple of minutes just talking through the structure of the decision-making business case. You all have read the document and understood the build, but I think it's really important to understand the flow of the document because I think it demonstrates what a systematic and robust process we've worked through under this programme. So obviously we start with the introduction and the case for change that we heard from Dr. Murray earlier, working through the clinical model, but then a very, very robust process to look at the options that would deliver the clinical model and how we would consider them. We've been through a few stages of assurance in terms of using the Joint Clinical Senate and NHS England Improvement to review early options, and then we went through a process of decision making prior to our consultation exercise. We then undertook the consultation exercise, and the decision-making business case outlines, as we heard earlier, about some of the key messages and themes around that. And we had a look at that. We took into account the feedback, and you heard from Andrew earlier about how we are addressing some of those themes from consultation, and that's again made very explicit in the decision-making business case. We had another set of including the final integrated impact assessment, which Andrew's mentioned already and Sarah's going to expand on shortly, as well as the Mayor's assurance process and also the process working through the Joint Health Overview and Scrutiny Committee. We then obviously concluded in terms of making a decision and working through what we need to implement and conclude the overall case. So maybe that gives members a flavour for the decision-making business case structure and the logic behind it. And Sarah's going to outline some of the recommendations of the decision-making business case for implementation if we support the recommendations today. So over to you, Sarah.
Thank you very much, Matthew. So just to be clear, I won't go through all of the detail in these slides because a lot of it actually has been covered already by other people. So firstly, the recommendation is that when we have completed our decision, that the Trust should implement the preferred option that we decide as commissioners. And that what we will do as commissioners, we will make sure through a reporting and the establishment of a strategic executive group and an oversight group, we will make sure that those recommendations are implemented appropriately. So I'll pick out a couple of the areas that came out through the IIA and that we have made recommendations on. Andrew's already mentioned a full travel and access strategy, and also that we should include within that things like access roads. We do know that may be an issue on some of the sites. And also that the Trust and the CCG will publish the travel action plan that comes out of the work around the strategy and the working group. We go on to the next slide. So some of the recommendations were around how we work with others, including local councils and transport providers. And I know that the Travel and Transport Working Group should do a number of things, but that should also include reviewing recommended potential alternative travel solutions for vulnerable groups, not just for everyone. So there are other options apart from the normal access to travel, including things like the Good Neighbour car scheme or dial-a-ride. So we need to look at every option as we go forward. And the other thing is that we need to keep on looking at the local strategies that we have, particularly around health inequalities, and we want to make sure that the outlined business case when looking at the implementation of the clinical model should ensure that there's appropriate access to district services and out of hospital services in conjunction with the CCG and the other stakeholder plans. So can we move on? Work consultation and from the IIA as a clear priority. And in addition to all of the work that's already been undertaken, it's really important that the Trust develop a detailed workforce implementation plan. And that will include recruitment and retention plans, and they will work in partnership with Health Education England, the Royal Colleges and local clinicians and stakeholders. It's also important that we continually review what we are doing, and we've seen that already around COVID. So the clinical model should continue to be developed, and it should be based on all the latest evidence that we have. So the Trust should report regularly on the implementation of the benefits realisation and the evaluation plan, and continually evolve those based on any new information that we receive. So I'm going to just draw your attention to the joint arrangements with local providers. We mentioned that there has been a lot of concern about impacts on neighbouring providers, and within the decision-making business case you have all the information on that. However, we will need to continue to work with providers, make sure that they are happy, and we have tested and reviewed all of the assumptions that we have in there, and make sure our implementation plans are developed that would support all of their requirements, particularly around capital. The other thing is that the district services need to be delivered and implemented and in place to support the patient flow and the operation of the specialist emergency care hospital, and that's to ensure that the district service enhancements have sufficient lead-in time and that we make sure that they can deliver as part of the whole model of care. I think Andrew's already mentioned the bed requirements, but I think it's important that the full bed requirements to 2930 are reflected, and this is set out here. There are a number of people that have highlighted to us, including through the consultation, but also through the Mayor's office, that actually we need to have a particular focus on some groups, including our BAME populations and our deprived populations. And we think we should commit in South West London CCG to work with local partners to undertake a further focused deprivation review specific to East Merton and North Sutton residents. This has been highlighted to us. We recognise this as an issue, and we want to determine whether there are any additional services which should be made available locally, and we will work with the Trust around things like district hospitals, but also primary and community services. If we go to the next slide. The outlined business case needs to have the funding confirmed, and so what we will need to make sure with the Trust is that there is future capacity within the hospital to design and incorporate not just for the finances, but also that there's a flexibility within the build so that we can respond in the future. So we will need to meet the requirement of the money, but also make sure that the build is able to deal with any future impacts that we might have, including future viruses or pandemics. Local health and care partners will actually monitor all of the impacts, and we will particularly focus on communities where there may be a differential impact, such as our BAME communities. Finally, commissioners should undertake further work in partnership with local authorities and with the Trust to appraise the additional services that were mentioned by Andrew, to see whether or not they can be located on district sites, and whether or not there are any other local care settings that we could work on to ensure that our local communities' local health needs are met. So I'm going to leave it there. All of the information is in the decision-making business case, and I am aware that all of the members of the committee have read that in detail, so you can pick up further information on the recommendations within that. So I'm going to hand it back now to Matthew for the CCG oversight of the recommendations.
Thanks, Sarah. So I think we've touched on this, to be honest. I think Sarah's outlined the real importance of the recommendations around implementation if we proceed to support the recommendations in the decision-making business case today. She mentioned the Strategic Oversight Group. In terms of the Commissioner role moving forward, that we will need to support the Trust's outline business case and full business case if we support the recommendations today. And I think you've got a sense of the importance of the recommendations that need to be built into that business case to make sure we address some key issues moving forward. So I think that concludes the presentation today, and we're now going to move on with the agenda. So I'm going to hand back to Jonathan as convener. Thank you.
Matthew, thank you very much, and thank you to everyone who contributed to that presentation. There was a lot of ground covered there, but I know it was just a summary of a lot of work that's been happening, well, over the past years, but in particular since the consultation closed over the past few weeks. Before I open it up, if this is all right, Chairs, to a general discussion, I just wanted us to note a couple of things. So the first thing is to say that as part of this process, the CCGs wrote to selected representatives, for example, local politicians, local authority representatives, and the Keepar St Helier Hospital organisation, providing them with an opportunity to submit a written submission to give us any additional information which has not already been included in the previous representations they might have made when responding to the consultation itself. And these have been provided, and we had 9 statements submitted by stakeholders. I'd just like to refer to those, just so everyone is clear who submitted statements. So we had statements from Surrey Adults and Health Select Committee, Chris Grayling, MP, Siobhan McDonough, MP, Councillor Elizabeth Daly, who's District Councillor for Bookham South on behalf of Mole Valley District Council, Councillor Paul Kennedy, who is a District Councillor for Fetcham West, Merton Council, Merton Conservatives Group, Sheldon Vesti, who is Chair of New Mill Quarter Residents Association, and also from Keepar St Helier Hospital Campaign Group. So we have 9 statements. The deadline for submission was noon on Wednesday, the 1st of July. All of the statements submitted by then are loaded onto and available for everyone to see on the Improving Healthcare Together website. And I know that was circulated specifically to all members of the committee so everyone could read those and look at those prior to the meeting. And these statements form part of the information provided to the committees for consideration at the meeting. So I just think at this point, I'm just going to look to the chairs just to confirm that your committees have seen those, and I think we should just ask your committees just to note that they have been submitted and that they've been noted by the committees. So just looking to Andrew Murray first.
Yeah, that's right, Jonathan. They were circulated to us all, and we've all had the opportunity to look at those and review them. So we have taken that into account.
Thank you very much, Andrew. And to Charlotte?
Yes, thank you, Jonathan. My committee have seen those submissions and reviewed them.
That's great. Thank you very much indeed. So now I'd like to move on to another opportunity that the CCGs gave to members of the public this time. Members of the public were provided with the opportunity to submit questions in advance of this meeting relating to the agenda of this committees in common. Again, the deadline for these questions was noon on Wednesday, the 1st of July, and I'm pleased to say we did have a number of questions submitted. It was made clear to anyone submitting questions that we wouldn't ask and answer every single question, but a process would occur where we selected from those questions a sample in order for them to be asked and responded to at this meeting, and that the criteria for that selection process was clearly set out as part of this on our website. So the questions that we received by the due time on Wednesday last were clustered into the themes, the sorts of themes which we've heard from the recent presentation. And then myself as convener, I reviewed all of these questions in detail, and I selected a question from each of these clusters which I felt were representative of the sorts of issues being raised to be asked at this meeting. And as a general principle, because people submitted a number of questions, our general principle was that there should really be just one question per organisation or person, so that we could hear from the broadest range of questions within our time allocation. So I think we received questions from about 20 members of the public, 18 or 20, something like that. And the full list of questions has been published on the website. I should say that we haven't published, generally we haven't published people's names, and we haven't published any personal information about people, but if someone was asking a question as a representative, for example, as a councillor, then we did feel it was appropriate to include that person's name. So that's why, if you look on the website, there might be a slight difference in attribution of those questions. So if that's all right with the chairs, I think I will, or I just should say, I think that to everyone who submitted a question, there will be replies going to each of you following the meeting. So with that, perhaps we could then turn to the questions which have been selected, and so I will ask the questions, and I'll look to see if there are people from the programme or the clinical advisory group or the other experts who are able to answer those. So the first question is about the clinical model, and it's as follows. Will there be enough beds between the new proposed hospital and St Helier and Epsom hospitals for those patients leaving the new hospital and others recovering from everyday operations and treatments? And I can see that Dr. Jeff Croucher, you've raised your hand. Would you like to answer that question for us?
So thank you, Convenor. So we have listened and responded to feedback from a number of areas, including the public consultation, the Mayor's Office and the clinical Senate recommendations. And we have extended our bed modelling plan until 2030. So all
All of our health and bed modelling takes into account that over the next few years we will have advances in technology and treatment and the working more closely with community services, so that what this will mean is that people will then have less of a need for overnight stay, and they will do so and will be supported with getting home sooner if they do need to go to hospital. So we expect the number of beds that's already been described, the 1,006 beds for the population for 25-26 for each of the shortlisted options. Currently there are 1,048 beds at Epsom and Helier Hospital, meaning that there will be an increase of 18. And that increase in bed capacity means we can care for more than 1,300 additional patients every year. And these beds at both the specialist emergency care hospital site and the district hospital sites will include emergency beds, unplanned and planned care, with about half being in the specialist emergency care hospital and about half in the district general hospital sites. So we're confident that those leaving the specialist emergency care hospital and subsequently receiving treatment at their local district hospital for rehabilitation or other forms of care will have the appropriate number of beds available to go alongside those that are receiving care or choosing care for planned treatments at a site local to them. Thank you, Convenor.
Thank you very much indeed for that. So perhaps I'll pass on then to the second question, again about the clinical model, and the question is as follows. In the event of another epidemic, what advantages for public health, patients and medical staff will result from locating what would be the only intensive care and ventilator beds available in the Epsom area, in the heart of a major cancer hospital which cares for immune suppressed patients under the proposal you are considering today? So is there someone, Dr. Russell Hills and James Marsh, perhaps Dr. Hills, you could?
Thank you, Convenor. So if the specialist emergency care hospital were to be located at Sutton, then what you would aim to have the separate access into the building. So the Royal Marsden access and the Epsom and Helier access would be separated in separate buildings with separate entrances, which would mean that Royal Marsden patients who may be immunosuppressed would be separated from attending the specialist emergency care hospital.
And we would certainly ensure that this would be implemented as part of the building design. So if, for example, to further improve patient care, we explore options for joint services, we would ensure that COVID or other future infection control issues would be factored into the design. And for example, we could explore a model such as we already have at Epsom with the elective orthopaedic centre, where we have a standalone building. Consolidating the services onto a single acute site would mean that the new facility would allow us to increase the number of intensive care beds from the current number of 22 up to 30.
And I think just following on, the most important point is that we know we need to act in order to make our facilities and workforce resilient to future surges in demand so that we can deliver care and improved outcomes for our patients. So bringing our services together in a new hospital site, which can effectively separate patients for infection control service purposes, will mean we can deliver this for patients and improve resilience in staffing. And as James has said, we'll have more ITU beds, and the new facility will provide more single rooms to care for patients that need to be isolated.
Thank you. Thank you both for answering that question. So I will then move on then to the third question, and this is in connection with the issue of other providers apart from Epsom and Helier. So the question is, has there been any modelling done to look at the external pressures of other surrounding A&E departments if St Helier and Epsom were to close? and replaced by one A&E unit at the Marsden Hospital. So that's the question there. I see Matthew Tate, you're happy to answer that? Matthew, you had your hand up, but I can't hear you.
Sorry, Jonathan, I was just waiting for my mute to come on.
Oh, can hear you loud and clear now, Matthew. Please go on. That's great.
Thank you, Jonathan. So a really good question. I think our work with other providers has been really important as part of this proposal. We've had them embedded in our programme architecture from early on. We have indeed done modelling for the impact of all services and how they will affect the other providers in the system. And part of that, an important part of that, has obviously been the A&E modelling. As part of that process, all providers have confirmed that they will be able to cope with the additional demand, assuming the appropriate capital and revenue support where appropriate, and that's been factored into the decision-making business case and the pre-consultation business case. We should also remember that as part of our model, an important part of our model for district hospital services is the provision of urgent treatment centres to support real local access to urgent care. I think it's important we recognise that as we addressed the question today, that's also been a key theme of consultation to make sure that we do understand the impact on our local providers. And whilst that's been raised a number of times, that hasn't identified any additional information in terms of our conclusions and our modelling alongside the impact on our provider colleagues. But it is really important to recognise that as we go to the implementation phase, if we supported the recommendations today, that all of those providers are explicitly involved in that to make sure we get that right as we move to the next phase. So hopefully that's a helpful response, Jonathan, to that particular question. Thanks.
Thank you, Matthew. I'm now going to move on to another theme, that of deprivation and health inequalities. And if members of the committees will forgive me, I sort of broke my own rules here because I couldn't choose between two questions. So I've selected two questions on this topic. And if I may, I'll ask them both and then see if they could be responded to together, if that's all right. So the first of these questions is as follows. The recent Public Health England report revealed the disproportionate impact that coronavirus is having on BAME communities. In the light of this, and given that 4 of the 66 areas across the catchment with the highest proportion of BAME residents are nearest to St Helier Hospital, why does the programme still propose moving acute services away from St Helier? Why has just 5 pages of analysis been completed to assess the impact of coronavirus on this programme? And why does this analysis not once mention the impact on BAME communities? And then the second question is as follows. Please rethink and reconsider your decision to shut St Helier Hospital. When Black Lives Matter is critical and something we should all be supporting, you choose to move hospitals like this from a deprived area to an affluent area. Does this make sense to you? Do you think it is fair, especially given the impact that COVID-19 has had on black and ethnic minorities? So that's the question. So I think I can see Dr. Murray, you have your hand up for this.
Yeah, let me start. I'm sure there'll be other people who want to come in on this because they're really pertinent questions and it's a really significant. So I've been chairing the South West London clinical cell, so overseeing our response to COVID in South West London, and that's involved the medical directors from the different hospitals, it's involved the medical director of the Mental Health Trust and GP leaders and the director of public health from Sutton. And we have been looking at our own data in South West London, particularly around this issue, because it's really important that we understand what is happening to our communities in the context of the COVID pandemic. What the data that we've got tells us is that older people, people from deprived communities, and people with BAME ethnicity have had an increased rate of hospital admissions and an increased rate of death in COVID. And that's very much in line with the Public Health England report. What the data also tells us is that there's a clear association between that and long-term conditions, and particularly poorly controlled long-term conditions, for example, diabetes. And we've got the data that allows us to drill down, look at ethnicity, where people come from, what conditions they have, and to make that association. So what that really tells us is that all the work we've been doing to date around, with a focus on health inequalities, but particularly around focusing on prevention, early detection and management of long-term conditions, is really critical to prepare people for pandemics like COVID, to get them in the best possible condition to improve their outcome. The work that we're planning in the clinical model, where we repurpose the district hospitals to work very much in partnership with community teams, with general practice, and to resource them to manage long-term conditions more effectively, it seems even more pertinent and critical now, given what we've learned from COVID. So the plan to have specialist teams in the district hospital sites to have good access to diagnostics at both Epsom and St Helier, that will mean primary care and community services can better investigate and support and manage patients. It is really, really important. I think the other thing to say is that what we've seen through COVID is that when people are critically ill, bringing specialists together onto one site to more effectively manage those critically ill patients is really important. If you look at the response across the country, that is the universal model, because it is not disputed in the NHS that consolidation of specialist services saves lives when people are critically ill. And given that's what we're proposing in the Specialist Emergency Care Hospital, this adds even more weight to the argument for the clinical model. I think the other thing we've been particularly mindful of in the response to COVID is the importance of good infection prevention and control. So having the option to create a specialist emergency care hospital as a new build on the Sutton site, where we can build it to the highest standards of infection control, with clear segregation between areas, with a high percentage of single rooms, means that in the future we would be in a much better position to manage a future pandemic like COVID. Now, given that we've seen a disproportionate impact of COVID on deprived communities, older people, and particularly the question relates to people with BAME ethnicity, those are the very people who are going to benefit most from this new model of care. So if anything, what we've learned really reinforces this, and we need to accelerate this work. It's absolutely critical we deliver this now so that we are prepared for future pandemics. Let me hand over there, because I can see there's other people who want to come in. I've said plenty there.
Andrew, thank you very, very much for that. Yes, I think there are a couple of others who perhaps want to come in. I think the first hand up there was Dr. Vasa Ganagrasenim. Do you want to add something to what Dr. Murray has said, Vasa?
Thank you, Jonathan. Yes, I would very much like to. Yes, I think we all agree that the impact on deprived communities, on vulnerable people from black and minority ethnic communities is critical to this program and every program in the NHS, or actually across life in London and England, which is why there has been a lot of studies, a focus on the integrated impact assessment, and within the consultation report we have a lot of evidence of the work just been done. But as a clinician, I have learned three things from COVID. Firstly, as a Merton clinician, I have seen Merton citizens step up together, work as one, be it in hospital, be it volunteers, social care, primary care, statutory services, pharmacy services. Wherever I looked, I saw that people stepped up, and at the hour of need, what needed to be done was done. Now, the challenge for us is to capture this spirit, channel this positive energy, this force, and develop this health and social care well-being model which our patients need, our public need, and address the social determinants which impact adversely on health outcome. and deal with health inequalities. The second thing I learned is the survivors of COVID. The people who survive COVID need looking after in the short term, in the medium term, and in the long term. And we need to have fit-for-purpose buildings closer to these communities so that we can look after these people to help them heal from the insult, the injuries caused to them by COVID. The third thing is the most important bit for me, is the pre-COVID bit. How we make our vulnerable communities, be it due to deprivation, be it due to age, frailty, or ethnicity. How do we make our communities COVID fit so that the next time something comes along, they are in a better shape? Now, the early years lost life, the communities where their lives was already stolen, COVID came along and robbed a few more years then, and they feel it, and I feel it too. And for me, if we want to stop this robbery, the early loss of life, we got to get people fitter now, so that their hearts, their lungs, their kidneys, every organ which suffers injury from COVID is in better shape, so that the early loss of life doesn't need to be a recurring event. To achieve that, we have to go and develop a well-being model, a social contract, a social covenant, you could say, with our communities, based in hospitals closer to our communities, to develop this health and well-being model. And this new bill, fit for purpose, I'm sure will achieve it.
Thank you very much indeed. I think I also saw a hand up from Dr. Amir Hassan. Did you want to come in, Dr. Hassan?
Yeah, just a few points to echo what's already been said. I've been on the front line in the emergency department dealing with COVID patients, and fully understand and appreciate the concerns of everyone, not just from the BAME community, but also from people from deprived communities or people who are at risk groups. And to put things into context, we've managed the COVID crisis generally well. We haven't tipped over. We haven't had to make the difficult decisions where we decide to go into a mass casualty situation and limit treatment. So we have managed this COVID situation relatively well. And it's not just been the emergency department, it's been the ITU, it's been the general medical wards, and the whole trust has really pulled together to get this done in the best way that we can do. The only thing I would say is that we've done it in the best way that we can do, given the facilities that we have. And what that's often entailed is that we've placed patients into cohort areas rather than into side rooms where it's better for isolation. We've had to move patients from the emergency department up to across the whole hospital to the going through lifts, going through wards, going through corridors, where you're exposing the general population and exposing patients as well. So what we really need to move to is having a situation where you have an emergency department joined with an acute floor, where you have all your acute services based within a close locality. It's much better for infection control. It's much better for the patient pathway. And it's something which can be done with a new build, and unfortunately I don't believe either the Epsom or the St Helier site can facilitate this, because the restrictions there are so many and the facilities are so poor. And that's all really just what I wanted to put in.
Thank you very much indeed. The very fulsome and helpful answers from all of you. Thank you. So if there are no one else, I will then move on to the next question, and this relates to travel and access. So the question is as follows. It is good to hear that the original NHS bus service from Epsom Hospital to St Helier Hospital will be extended to Leatherhead. Can it please also be extended to Fetcham and Bookham, which is in the area of Epsom St Helier NHS Hospital Trust? Can there be better travel arrangements to a new proposed hospital in Sutton, if not by the NHS bus service? So, for Sarah Blow, I can see that you've got your hand up.
Yeah, so thank you very much. So first of all, yes, that's correct. We are committed to extending the H1 hospital shuttle bus, that's the route between Surrey and Merton, so that there's an improved service both for patients and for visitors and for staff. But we'll also look at the feasibility of areas such as Fesham and Bookham, so it's good that this has been raised, and I think it's important as we move forward. I mentioned earlier that we're going to set up a working group that will look at travel arrangements going forward. So I think it's important we get that in place and that people get involved in that, and that we end up with a really developed, detailed travel plan. And we work with all of the transport companies and with the local authorities to make sure that we get that right. We want to make any decision that we make as accessible as possible for our local populations, including our staff and visitors. So, yeah, I don't know if you want any more, but I think that probably covers it.
Thank you, Sarah. I think that does answer that question. Thank you. And then the final question I selected was again specifically about COVID-19, and a number of questions were about COVID-19. So this is the question selected. So it says, how would the region be served currently? Sorry, how would the region served currently by Epsom and Helier Hospital cope in the event of a future virus, for example, of the kind currently existing COVID-19? Channel 4 News focused closely on the Epsom St Helier ICU and how it managed during the worst of the crisis in March, April. And the coverage was overwhelmingly positive about the life-saving service being provided. And that's in was See Inside an ICU, Channel 4. In the plans ahead, the ICU would cease to exist and the hospitals be radically downsized and more like cottage hospitals. So, would this not put the local population at greater risk? So that's the question. So I can see Dr. Murray, you've got your hand up. Do you want to answer that one for us?
Yeah, sure. I think I saw Daniel's hand, but let me go first as a commissioner, and obviously also in my COVID role that I referenced before. And I think some of this obviously is similar to the answer that I gave to the previous question, but in essence, what the new specialist emergency care hospital on the Sutton site would give us is better specialist care because of the ability to bring specialists together into a single team, so that we have consultant cover round the clock and the right level of workforce to deliver clinical standards. We'd have the right standards of infection prevention control with single beds. We'll have more ICU beds available in the new model. And of course, the advantage of us proposing the 3-site option is that there's increased flexibility, where you've got protect particular groups of patients. The way the proposal is set out, it gives us much more flexibility to do that. But on this particular one, I'm sure Daniel could add even more to it than I can.
Daniel, would you like to come in now?
Yes, I just want to basically endorse what everyone has been saying. It's really clear that the whole of the NHS has had to go to extraordinary lengths to cope with this huge increase in very sick patients. And it's very clear to us at Epsom and St Helier that we've had to contend with two things on top of what nearly every other organisation has had to cope with. And the first is having our workforce so spread out and being very fragile and not resilient as a result of trying to run acute services on 2 sites. And the second is the fabric and quality of our buildings, which have given us huge issues to contend with in managing COVID well. And I think Mia gave some very good examples, and Dr. Murray's just given some good examples too of things we've had to do. So I am sure, and people who work in Epsom and St Helier are sure, that if we have a purpose-built modern specialist emergency care hospital that has the right facilities and we can put our staff in one place, we will be able to respond to pandemics like COVID much better in the future.
Thank you very much indeed, Dr. Murray and Daniel there responding. So those were the questions selected, and as I say, the full range of questions are on the website. So I think where we are on our agenda is I think we're now at agenda item 7, which brings us to, I think, that part of the meeting where I'm going to ask the two committees to really carefully consider all of the information that's been laid before them at the meeting and relating to the questions being asked as well. So just to remind you, the information that you have before you is the feedback from the consultation. You've got a phase 3 integrated impact assessment report, which has some suggested enhancements to what's being proposed there, and that was produced by an independent steering group. You've also today, or over the last day or so, had some further statements from key stakeholders, and we've just gone through some questions from the public as well. And of course, we've got the document, the main document for the meeting, the decision-making business case, which, just to remind you, has in it some analysis of discussions which happened with the Joint Health and Overview Scrutiny Committees, and with the analysis by and questions from the Mayor of London as well. And in the conclusion of that decision-making business case, there are 24 recommendations to support the proposals being made. So I just wanted to remind you that we have all of that information, and I'm very well aware also that members of both committees have been thoroughly involved in the analysis of the outcomes from the consultation since it concluded throughout the last few weeks. So I'd just like to remind you of the question Andrew Dimitriades raised early on in his presentation, where he asked us to consider all the evidence, and then, having considered that, for the committees to make a decision about the best solution that addresses the case for change and delivers the clinical model for Epsom St Helier's hospitals. And so with that, I just think maybe we should ask, or it's time for us to go back to the committees, and I perhaps will ask the committee chairs to respond and ask their committee members if there are any further questions they would like to ask in helping come to a decision on the proposals before us today.
Thanks.
So Dr. Murray, please.
Shall I come in? And
yeah.
And obviously we have had the chance as a governing body to look at this at various stages in the process, and we've been able to deliberate and discuss since consultation closed. So the information we're seeing today is not all new to us. I do know that some of my committee members do have just a few further questions that they might want to ask at this point before we then come on to making a decision. So is it okay to turn to people now, Jonathan, just to...
Why don't we do that? I mean, if you don't mind, Andrew, why don't we have I'm sure there might be also questions from, sorry, so why don't we'll do a question from South London and a question from Surrey. Why don't we do it like that?
Okay.
Just to
that'd be really
have some balance, if that's okay. So, yes, why don't we have the first one then from South West London?
Well, I know that Susan Gibbons, our lay member for patient and public involvement, wanted to ask a specific question. So, Susan, shall I turn to you?
Okay, thank you. Yes, we've heard quite a lot of helpful feedback from the public questions, but mine's perhaps a bit more specific. We noted today that the clinicians from St George's and Epsom St Helier have written around the consolidating of renal services. It would be useful if someone could just expand on whether the deferment of any discussion on renal services will have an impact on the clinical model and the wider IHD proposals.
Thanks for that question, Susan. I can see that Sarah Blow has her hand up. So, Sarah, are you able to respond to Susan Gibbon on that question, please?
Yes. I think that Andrew mentioned this earlier. The clinicians actually in their letter, they were collectively very supportive actually of the case for change around improving healthcare together and on the consolidation of the specialist services onto the single site. Their proposal, they thought, would add additional benefit around renal services. So from our perspective, we and that's been through the clinical advisory group, there is a view that could well be potentially a very positive thing, but we aren't going to consider it as part of the case today. So what we are suggesting is that there is some more work done outside, and then that this is looked at through the outline business case stage. And then if there is any additional process required at that time, then we follow process then. But it doesn't impact on our ability to make the decision today. In fact, they are supportive of the model of care. It's just that there is some further work to be done which could provide additional benefits in the future. But we will look at that, but we're not making that decision today.
Okay, thank you.
Thank you very much, Susan and Sarah. So maybe I should go to you, Dr. Caniff, for Surrey Heartlands. Are there additional queries from your committee, do you think?
Thank you, Jonathan. Yes, I think we've got 2 or 3. So as you said, we'll jump between South West London and Surrey Heartlands. But my first question's from our audit chair, Jackie Burke, please.
Thanks very much, Charlotte. As members will know, I usually focus my questions around the finances and the financial model, and I've been grateful in the past for the amount of time that some members of the team have spent going through that model with me. But nevertheless, one or two questions still remaining. Can I ask, has there been much change in the financial model since the version that we saw with the pre-consultation business case? And if there hasn't been much change, are we still assured that that modelling is correct? And I guess in particular, given some of the discussion we've had this morning, does the model include consideration of the investments and the financial commitments of the other providers, which would be needed through the proposed changes in our options? And I'm presuming that the modelling will be completely refreshed for the outline business case. And so I guess I'm asking, will that give us the opportunity to consider changes in the economy since then, things such as changing costs in construction because of COVID? So I really just want to get a sense from the team, if I could, of those questions.
Jackie, thank you for that question. And I see that James Murray, who I'm sure is the right person to answer this, has put his hand up. So James, I'm going to hand over to you, please.
Right, I'll try and answer those questions and try and get them in the order they were asked. I mean, to answer your first question, we haven't made any significant changes to the model since we did the PCBC. We did an extensive exercise at that time, which was undertook great due diligence from regulators as well, and we reviewed that as part of the process, and we were happy that at the time that didn't require any amendment because there were no significant changes to the business case itself. To build on that for your OBC question, yes, indeed, we will refresh the whole model for the OBC, as you would do within any business case process. And when we're living in uncertain times, as we are now with economic and service disruption, that will need to take account of any of those issues that arise as we work through that. That, unlike the PCBC, will be run by the trust because it's their responsibility for doing the OBC and then subsequently the FBC. I chaired the PCBC process, so I had oversight of it, but I will be involved in the, as will your CFO from Surrey, be involved on the group that develops the next stage model as well. So we will have oversight on that and be able to work through the changes and assess the impacts as they occur. Obviously, as you say, there are economic changes. There were some optimism bias assumptions in the in the model as well, so those will come into play. That's why you have those sorts of things in there, but we'll work through that and make sure that we keep a hold of the financial envelope. In terms of the providers, as Matthew highlighted in one of his earlier answers, indeed we did take into account all the direct impact of that. It was relative to each of the options, so we did a detailed assessment with the providers on what cost impact that would have, and clearly that is something else that we will review as we go through the process. So if there are any changes or amendments to that, we'll pick those up at the same time, and the capital and revenue costs of those changes were built into the financial model.
Thanks, James. That's really helpful.
Oops, sorry.
That's excellent. So thank you for that. Any more, Jackie? You're happy on that?
I am happy.
Thank you very much. So Andrew Murray, perhaps go back to South West London. More.
Yeah. So the next question, actually, Pippa Barber, who's our independent nurse on the governing body, she had a key question that she wanted to raise. So again, I'll just turn to you, Pippa.
Thank you, Andrew. I've got a specific question. So we've heard a lot this morning, rightly so, about the hospital-specific services. And Sarah, Andrew and Vasa, you all mentioned the importance of primary and community services. Our CCG has got a number of strategies and plans for primary and community services. So my question is, are these plans sufficiently integrated with our IHT proposals, particularly in relation to the district services, to ensure that we're able to provide better continuity of care for our patients?
Thank you, Pippa. Lucy Waters, you've got you suggested you be able to answer this for us.
Yeah. Jonathan, I think Lucy would be a good person to answer, actually, because she's obviously one of the locality exec directors in Dutton working on this very thing. So I'm delighted that, Lucy, you've put your hand up.
That's exactly right. Thank you. And thank you, Andrew, and thank you, Pippa. So as the committee knows, in the original pre-consultation business case, we did incorporate our plans for out-of-hospital care, including the investment in primary and community services. But I think Pippa's point, her question is a really good one, an important one, because while there are already schemes in place, they have been developing at pace through the time that the improving healthcare process has been undertaken. So I think it's really important to point out that in the decision-making business case, a lot of that work on out-of-hospital care has the product, the impact that we've been able to have in as the work has been developing is reflected in that, and it also underpins and supports the bed-based numbers and the integrated care proposals that we've described. But that's not, I think we're all aware, that's just the starting point. The level of ambition that we have is much greater to do that level of integrated services around the needs of individuals, close to home, to deliver holistic, proactive care the way that we heard outlined by Dr. Murray when he was describing that repurposing and resourcing that we want to put in around our older and our deprived communities, very much focused around the district hospital sites. So I think as we go forward into the outline business case, we're going to detail further how we want to engage new stakeholders, how we want to do more work, not just around the integrated models of care that we have already. So we have Merton Health and Care together, we have Sutton Health and Care and Surrey Downs Health and Care. But how we're going to extend that further, how we're going to extend the partnerships, how we're going to build on the work that's been done around those the BAME populations, the older populations, how we're going to look at the district hospital sites as real hubs for those communities, how we can extend the services 7 days a week, 8 till 8, make sure that we're offering one-stop outreach services in the community, in people's homes and from those district hospital sites.
Thanks, Lucy. It's really helpful.
Thank you very much. That's great. Charlotte, if you don't mind, I realise that I've been advised that there's a joint question from Health Watch which has been raised, and I wonder if I could ask. I think it's Kate Scribbins. You'd like to raise a Health Watch question, and this might be a good time for you to ask your question.
Yes, thank you, Jonathan. Can you hear me?
Indeed, yes.
Okay, so I'm asking this question on behalf of the Health Watches, both Surrey, Sutton and Merton. And my question falls into two parts. The three local Health Watch feel that during the Commissioner-led IHT pre-engagement and consultation phases, a lot of resource has been invested in building many positive connections and relationships with community and voluntary community faith sector groups, both large and small, as well as with individuals who've taken the time to get involved in this process. If the baton for engagement is passed on once a decision has been made today, it's important that these relationships are maintained and that the interest and energy harnessed during the process is maintained so that communities have genuine involvement going forward. So my questions are, once commissioners have made a decision about the location of these new services, please can you explain how engagement with the public across the geography will be carried forward as plans are developed? And secondly, could you also please explain which organisation will own responsibility for patient and public engagement once a decision has been made? Thank you.
Kate, thanks very much for that. And I see Matthew Tate has volunteered to provide an answer, and also Daniel Elkeles from the Trust. But perhaps, Matthew, you could go first.
Yes, thanks, Jonathan, and thanks, Kate. I think it would be a good time really just to acknowledge the support of Health Watches across the system in designing and supporting our extensive engagement process that we've run, both pre-consultation and as the formal consultation exercise itself. And as Kate recognised, we've used multiple methodologies to try and get comprehensive feedback to inform our plans and developments going forward. And that's embedded in our operating model that we've established within the programme. In terms of the ownership point, I think there's two aspects, and I think it's really helpful that Daniel's put his hand up, because I think he will own an awful lot of this moving forward as the Trust. But I think it's important to recognise that the important role of our strategic oversight group will be to make sure that we are seeing that effective public engagement embedded in everything that the Trust do as they develop their outline business case and full business case. But I'm sure Daniel will want to highlight and take responsibility for picking up the baton of the effective engagement that I think we've done as a programme with the support of communities and Health Watch.
Yes, I'm very happy to pick up that baton for Epsom and Helier. I think we believe in our Trust that the Health Watch contribution is enormous to helping us provide great patient care, and completely committed to setting up the relevant stakeholder groups to help us design a really good hospital and the refurbishment of Epsom and Helier going forward. So I'm absolutely happy to commit to that.
Thank you, Matthew, and thank you, Daniel, for that. And hopefully, Kate, that provides you and all of the Health Watch representatives with the assurances you are looking for that question. Is there anything else you would like to ask?
No, that's it. Thank you. Thank you very much.
Thanks, Kate. So, Charlotte, sorry, I sort of rather interrupted our ping pong match between the two committees. So perhaps I can go back to you. Sorry, Heartlands. Any more questions?
Thank you, Jonathan. Yes, so we've got a question about the clinical model, specifically around maternity, from our registered nurse, Julia Dutchman-Bailey. Julia, over to you.
Thank you. So through the clinical model, we are sure that there's going to be good local access to hospital services, including the continuity of care for maternity. But I just wonder whether somebody can just touch on and reassure us a little bit further about that continuity of care for maternity.
Thanks, Julia. And Dr. Croucher has put his hand up for that one. Jeff, do you want to go with that?
So, Julie, thank you for that question. As a clinical member of the clinical advisory group, I, with some of the other GP clinical chairs, have worked really closely with other senior clinicians from maternity, from paediatrics, from neonatology and the midwifery services. So the principle that continuity of care within maternity services is an essential principle that we've included in the clinical model. So in terms of local maternity services and throughout the development of the clinical model, maintaining good local access to maternity services is deemed to be essential. So for example, antenatal appointments will continue to take place with midwives in community clinics or at the district hospital site. For women who have had low risk births, they will still have the choice, who are deemed to be low risk, they will still have the choice to have their baby at home, fully supported by healthcare professionals in their own environment. So for those women who don't have complications and who typically will be able to go home shortly after a hospital birth, they will continue to be visited by local midwives and supported by other local community clinicians. For women who need an obstetrician or a consultant-led birth, and those with higher risk of complications will be cared for alongside and in conjunction with the other specialist services on the site of a specialist emergency care hospital. And this is because we want to follow best evidence, best clinical practice, maintain some quality and clinical standards within maternity services, and deliver that with a 24-hour consultant-led cover of care. Julie, I hope that helps.
Thank you, that's really helpful, thank you.
Thank you very much, Dr. Crutcher and Julia, for that. So, clinical chairs, other questions? Andrew?
I'm not aware of any other questions from the South West London Committee. Maybe I'll just quickly check if anyone has got anything that I've not turned to you for. Do you want to raise your hand now from my governing body? No. Okay.
No. Okay.
That's a no then from us, Jonathan. Thank you.
Thank you very much, Charlotte. It looked like you perhaps had something else from your committee.
Yeah, if I may, just one question of my own, if that's all right, Jonathan. Just to Daniel. We've heard now, we've got a set of very robust recommendations here, 24 I think, Jonathan, you said. Can I just clarify with you how the Trust is going to work with partners to ensure that these recommendations are all implemented?
So yes, so it's really clear to me and people in Epsom and Helier that we've only got so far in this process because we have worked together so well as a team across the whole of the local NHS. So you have our absolute commitment that that's how we want to carry on with the programme. So we have been in the background working up a draft programme structure should you make a decision today, and I look forward to being able to share it with you next week, and it does include all of the relevant NHS partners that you would expect.
Thank you, Daniel.
Thank you. Sarah Blow, you'd like to come in, I think.
Yes, and I think I just wanted to remind people of the point that Matthew made earlier, which is that we as commissioners will make sure that there is a strategic oversight group, and that we will include both ourselves and the regulators to make sure that the Trust is implementing the recommendations that we set out. So obviously we know that Daniel is committed to it, but there will be a governance structure that will allow us to be able to have oversight of that process as well. So I just wanted to give you assurance on that side as well.
Thank you. And Jonathan, may I just pause and ask my governing body whether they have any other questions to ask?
Yes, of course, Charlotte. Yep, please do.
So do raise your hand.
Nothing from me, Charlotte, thanks.
Thanks, Jackie. Okay, I can see people saying no and no hands raised. Thank you, Jonathan. Thanks for the opportunity.
Thank you for that. So I've just got one, just to absolutely be clear, and this is really directed to both you, Charlotte, and Andrew. Just to be clear that you, if a decision is made today, you as clinical chairs of the clinical commissioning groups, you think that there is the governance in place to continue to have this oversight and scrutiny of the implementation going forward. So Daniel sort of talked about his side of it, but I think it's just useful for us to hear that from a commissioner's point of view, the structure will be there as well.
Thank you, John. Well, helpfully, Sarah's just outlined, hasn't she, that we'll have a strategic oversight group and a strategic executive group, and the oversight group will include representation actually from our regulators, and that's going to be the forum to monitor delivery of all those recommendations. So yes, from my perspective, and I'll obviously hand over to Andrew for his input, but from my perspective, I think the governance is there and ready to respond.
Yeah, let me just follow on from that then, Charlotte. Thank you. I think it's really key. I mean, as governance stands, Epsom St Helier will need to have commissioner support for both the outline business case and the full business case. And I think any decision we make today will be dependent on agreement that we're going to have those oversight groups to make sure the recommendations are delivered, and that our ongoing support for both the outline business case and full business case would be contingent upon meeting those recommendations. The consultation has given us some really rich information and some key themes which the recommendations are built on. Therefore, it's really important that we see them delivered. But I'm confident with those two groups in place that we will have the right governance and the right overview and scrutiny of implementation. And I think that's really important. We take this responsibility very seriously.
Charlotte and Andrew, thanks for that. I just think it's worth just everyone hearing that from all the principal parties. So thank you for that. So you're both as committees not aware of any other questions. So if that's the case, I think we've come to a time for just ensuring all the deliberations have happened and really considering whether, having read everything, been through the whole process and hearing everything today, whether you think there's anything from both of your committees' point of view, any material impact in relation to the rankings of the proposals set out in the documentation, and perhaps I can also just remind you of the resolutions which it's proposed that we put to the committees in a moment, and they're as follows: to agree and adopt the clinical model for delivery of district hospital services and specialist emergency care hospital, to agree that the preferred option for the location of the specialist emergency care hospital is Sutton, with the continued provision of district hospital services at Epsom Hospital and St Helier Hospital, to agree and adopt the recommendations from implementation, which we've talked about, which for committee members they're in the decision-making business case, but they were taken out and put in an Appendix 1 to the papers you all received for this meeting. So that's the reference Appendix 1 there, but they are the recommendations set out in the decision-making business case. And the final thing is to establish a strategic executive group and strategic oversight group to monitor the delivery of the recommendations throughout implementation. So I wonder if I could just pass back to you and your committees to reflect on those issues, just to see whether you think you are in a place ready to make a decision. So, yep, Andrew, you're nodding, so I'm going to pass to you first.
Sure. So I mean, obviously, Jonathan, we've as a governing body, we've discussed and deliberated on what we've seen come out of the consultation between the end of the consultation and now. Our collective view was that, if anything, that had reinforced our view that Sutton was the right option when we consider the needs of residents in South West London and Surrey. We also thought the themes that came out from consultation were incredibly important, and I think we've reiterated that a number of times, that the recommendations therefore are also critically important. I mean, this is such an important decision. I would really like the opportunity to just turn to my individual committee members one by one and hear from them directly as to whether there's anything they've heard today that's changed that view, and to get confirmation from them that they are completely confident we want to support all four of those questions that we've been asked. Is that okay if I'll just go around one by one, because I'd really like to make sure we're all totally behind this.
I think that's really appropriate, Andrew, particularly as we're meeting spread out online. I think we just need, or you as chair, I'm sure, from everyone. So yes, please go ahead.
First into Susan. Susan has been our lay member for PPI, and I'm just going to turn to those who are voting members at this point. So Susan, could I just hear from you?
I can confirm that I've not heard anything that would change my opinion, and I agree to the 4 proposals that are put forward.
Okay, thank you, Susan. That's very helpful. Vasa, as GP Chair of Merton Borough Committee, I would really appreciate hearing from you.
Thanks, Andrew. Yes, I have not heard anything throughout the consultation or up to today, which makes me change my mind on the previous recommendation. And I'm really keen and eager to get on and now work with the team to deliver the hospital. And also, more importantly for me, the out-of-hospital aspects of this service model.
Okay, excellent. Thank you, Vasa. And then Jeff, as the GP Chair for Sutton Borough Committee, who's also been through this now.
But also, it has been a pleasure. I think it's been one of those processes where I really did want to understand fully what was going on through the whole process so that we can get to this point today. So I confirm that I understand the content of the 4 resolutions. I haven't heard anything that alters my view, and I can confirm that I support the adoption of each of the 4 principles resolutions that are stated today in front of us. Thank you, Andrew.
And then finally, the final voting member today is Sarah Blow, our accountable officer. So just to turn to you, Sarah.
Yes, thank you. No, I've heard nothing today that would change my view of the recommended options. I would like to say that I think, as you said, Andrew, this is a really important decision for our local populations, and it's really important that we make the right decision. And as a member of that local population, as a resident, I think it's a really important decision. And on that basis, I fully support the recommendations set out.
Okay, so Jonathan, that allows me then to be in a position to tell you that the South West London CCG governing body in this committee and commons setting does support those 4 recommendations as set out on the slide in front of us.
Andrew, thank you very much for that confirmation. So can I ask the same question or adopt the same strategy then with you, Charlotte, for Surrey Heartlands CCG members?
Absolutely, it would make sense. Without repeating everything that Andrew said, clearly our governing body are not coming to this call today. We've had plenty of opportunity to discuss both programme boards, governing body seminars, committees in common, and obviously the updated integrated impact assessment. So I'd like to do the same if I may. It's always hard when we're not all sitting around the same table. So I'd just like to go one by one to each of my voting members to seek their opinions. So can I start with Jackie Burke, Audit Chair, please?
Thank you, Chair. Yes, I can confirm I've had all of the information and all of the detail that I need to be able to support the 4 resolutions.
Thank you, Jackie. And Julia Dutchman-Bailey, our registered nurse on the governing body, please.
Yes, thank you. I haven't heard anything that's going to change my view, and I support all 4 recommendations, or resolutions rather. Thank you.
Thank you, Julia. And Russell Hills, our GP clinical leader for Surrey Downs, and actually I must say here, he has led this clinical programme right up until the change of chair in April, so has been along this whole journey with South West London.
Thanks for that, Charlotte. And yes, as a local GP in Surrey Downs, this has been a hugely important piece of work for our residents, and I'm completely satisfied that this is the right decision. So there's nothing today that has changed my mind, and I support the 4 recommendations that are in front of us.
Thank you, Russell. And then finally, to our last but definitely not least, our accountable officer, Matthew Tate, accountable officer of Surrey Heartlands CCG.
Thanks, Charlotte. Yes, I can confirm that I fully support the 4 resolutions proposed today. So thank you.
Thank you. Well, in that case, Convenor, I think I have heard clearly from Surrey Heartlands CCG governing body that they've reviewed and considered the feedback and evidence to date, and that we agree the resolutions as described on the slide in front of us. Thank you very much.
Thank you very much indeed. So I think then I've heard sufficient as convener to, and I think you both confirmed to me as chairs of your respective committees that your committees have approved the resolutions as set out here, which I did read before. I'm not proposing to read them again. So I think just for the record, this is the decision-making moment. Those resolutions which are set out are on the screen at the moment. If I could ask you as chairs just once more just to confirm that your committee in favour of all of those 4 resolutions, that will be the moment of decision. So Charlotte.
I can confirm, Heartlands CCG approves the 4 resolutions as described in the slide in front of us. Thank you, and thank you everyone for all your work.
Thank you. And Dr. Murray.
Yes, I confirm that South West London CCG governing body approves all those 4 resolutions, and I think I just want to also give my thanks to Jonathan.TV for convening the meeting, but also for the team who've worked tirelessly on this. I think it's an incredibly exciting moment as we move forward now with this project. I'm confident it's going to improve the quality of care for our residents across South West London and Surrey, and I think it's just such a really important decision we made today, so thank you.
So thank you very much indeed. So that is decision has been made. So thank you everybody for your understanding and patience with the meeting today. I think despite having to use the technology, I think we've had a detailed and varied discussion. We've heard some important questions being asked and we've heard the answers. We've had some assurances from the key players going forward from the trust and from the CCGs that all going to cooperate together to deliver the decision that's been made to work towards the planning for the Specialist Emergency Care Hospital to be on the Sutton site and to implement the recommendations in the decision-making business case. So with that, I should just formally ask, I guess, if anyone has any other business to raise before the committees. I wasn't advised of any before the meeting, but anyone? Andrew, you're shaking your head. Nothing from you, Charlotte, and no one else on the call. I can see no hands being raised, in which case, once again, thank you very much. And with that, I'll declare the meeting closed. Thank you all for your attention.
Thank you.